Good day, everyone. My name is John Pullman. I'm the Executive Director of the Accountable Care Learning Collaborative. I want to thank you for joining today's webinar, which was not on the schedule, but due to recent events, we added this one. I also want to thank Western Governors University, where the ACLC is housed, and appreciate their support in advancing value in healthcare. Just so you are aware, this is mainly presentation. There's a lot of data and a lot of slides, so hopefully you're able to log into the Zoom platform to fully follow the conversation. We'll record it, we'll send out slides and recording afterwards if you're not in a position to do that now. We won't have a lot of time to do Q&A at the end, but there will be a section for it. Type in your questions along the way if you have them. We'll also track them at the end and try and get back to you. Just want to hit a couple, just two announcements up front. Work group meetings are happening always the third Tuesday of each month. There are 4 work groups. This September, this one is an important one because it's the last virtual one preparing for the in-person meeting which will all the work groups be able to meet in person as part of that area. Each work group is working on one topic right now. That's the most abbreviated. We've made the topic for each of them, but encourage you to join those calls. If you have any questions about it, just email one of us about when we can get you registered for that. And speaking of the member meeting, our next member meeting is coming up. It's in DC, October 23rd. So the afternoon of the 23rd are work group sessions, and the morning of the 24th is the ACLC plenary session. We do have, it's couched after the LAN Summit for those who might be coming in town for that. We're honored to have CMMI Director Adam Bowler coming to do a keynote and conversation and address our members. It's a good chain of CMS presence in ACLC lately. We're putting together also some really informative data elements like the presentation you'll see today, as well as some good interaction. So make time for that. The room block ends on the 24th of this month. Okay, we are going to get into this. We have with us today 2 experts who have done a lot of immediate analysis on the Medicare Shared Savings Program results. These are the performance results for 2017. And this is a preview of something that will be published soon. First, I have with us Dr. David Muhlestein, who's the Chief Research Officer at Leavitt Partners. Welcome, David.
Great to be with you.
Dr. Muhlestein is the research officer, I mentioned Chief Research Officer at Leavitt Partners. He's also a visiting fellow at the Accountable Care Learning Collaborative. He's also a visiting fellow at the Duke Margolis Center and an adjunct assistant professor at the Dartmouth Institute. We're grateful to have him. We also have with us Dr. Will Bleser, and Dr. Will Bleser is a research associate at the Margolis Center for Health Policy at Duke University. Hello, Will.
Pleasure to be here, John and David.
Happy to have you. Will works on a number of things at Duke, including payment and delivery system reform. He works closely with our co-chair of the ACLC, Dr. Mark McClellan and Rob Saunders, on topics related to accountable care, but he goes beyond to Medicaid expansion, Medicaid incentive programs, pop health, and emerging state health policy issues, and beyond. So we're grateful to have Will with us and probably use him in the future as well. I will, again, we have a lot of slides to go through, and Will, I think you're going to do the majority of those. I'll turn the time over to you.
Great. Thank you, John. And just want to make sure everyone can hear me. Last check. We good, John?
Yep, hear you well.
Great. So welcome, everyone. Thank you for tuning in. And anyone on the South Atlantic shore, please stay safe. I know things are getting kind of crazy down there. So we analyzed the new year of Medicare Shared Savings ACO data that was released about 2 weeks ago. And on this first slide here, the results overview, the tagline that we're going with for this, hopefully to be published soon, is half a decade in, improved results and net savings. And as a quick teaser of what we'll go into in more detail, the program saw net savings for the first time. I put an asterisk there, and I'll talk more about that later. over 300 billion, about $35 per beneficiary in savings. The likelihood of shared savings when we looked across ACOs was higher among ACOs who have been in the program for longer, especially after the third year. ACOs led by physicians, even if they had lower quality. ACOs that were of larger size, especially if that was within the breadth of hospital-led ACOs, and then also ACOs with higher benchmarks. And then on quality, the average quality score did remain high. It was not correlated with spending, which is something we've seen in previous years, but it was higher quality was associated with lower or more efficient benchmarks and physician-led ACOs.
Sorry, Will, there's a lag, and sometimes, let's see, are we on the right slide?
That's okay. So a quick overview of the population of ACOs in 2017. There's over 472. That's up about a net of 40 some odd from last year. They have over 3 years of experience. It's about a half year more experience on average than previous ACOs, and you'll see the distribution, but the notable changes are fairly similar, but we're seeing more track 3 ACOs. That's the most advanced track in the current MSSP program. The quality scores were very slightly lower, but I don't want to draw too much attention there because the metrics change over time. And anything else, David, that you'd like to add on high-level comparisons?
Just one thing that I'll highlight is the increase of ACOs. And so while there was a net increase of 40, there were around 90 new entrants into the program this past year. And so there's what we're starting to see is a fair amount of churn where ACOs are dropping out of the program more so than what we've seen in some past years. And so some of this is organizations that just aren't successful and decide they're going to kind of move away. Sometimes we're seeing ACOs start to merge together, but certainly a much larger churn in terms of people moving in and people moving out than we've seen in some past years.
Thank you. And on the next slide, that's so here we're showing a sort of a high-level overview of performance and savings over time. And a few things to note would be that as the program has gone on, the likelihood of shared savings in the average ACO has increased from about a quarter of ACOs to about a third of ACOs are achieving shared savings by 2017. The gross program savings reached over $1 billion for the first time, and again, the net savings were positive for the first time at $35 per beneficiary, but we'll discuss a little bit more on this later.
One thing I would point out is when you look at these net savings, when the average beneficiary costs $10,500 per year, they're pretty minor. And any of those previous losses, they were also pretty minor. And so it's great to see the program moving in a positive direction, but there's still an open question about whether or not ACOs are ultimately really going to meaningfully move the cost curve. And it depends on what you mean as a meaningful movement. But if we're thinking 3, 4, 5% savings, there's not strong evidence yet that the program has the ability to do that. And so there's obviously policy questions about what you could do to drive more savings out of the system. But keeping in mind that it's also a voluntary program, and if you just want to cut the costs by reducing payments or something, people are going to leave that program. And so there's still that open question about just how much we can use it under its current iteration under shared savings to really drive down the net cost of care.
Thanks. Hey, David, just want to jump in. We've got a crackly signal on your sound, and it actually came in a little bit on Will's too. We'll keep going, but if you think there's anything you can do to increase the clarity, it could be hard if it's over internet, but just look to see if there's anything you can do as we continue. So.
And this is Will. Can you hear me better at all?
I think so. Keep going. I'll let you know.
Great. So moving on to the next slide, which is ACOs looking at different cohort start dates. So here you're looking at when an ACO started. Again, their size and their net savings, their average quality score over time. A couple things to note is you'll see that the net savings does improve based on how long you've been in the program. ACOs that started in the first year ranged on an average of savings from about $120 to $180 per beneficiary, depending on which cohort they were in the first program year. And then there's not really anything noticeable going on with quality other than the scores were generally fairly high each year. So on this next slide, we're visualizing that so you can see what we're talking about. When I called out that the percentage of ACOs achieving shared savings really does jump after the third year, which was a pretty substantial jump there. And this will come into the policy implications later. And then on this next slide, we were interested in looking at how size was correlated with shared savings. And in previous years, we tended to see that the larger an ACO got, the lower their likelihood of shared savings. And this year, it wasn't as clear. We saw that the pattern really depended on the type of ACO. So for example, hospital-led ACOs, which in this graph are in orange, that pattern still held. But if you look at the blue and the gray bars, which are physician-led ACOs and integrated ACOs, it was more of a normal curve of shared savings by size.
And previously, when we talked to organizations, we saw that the smaller organizations had kind of an easier ability to make changes. And you think of that in a practical standpoint. If you've got a few dozen doctors and that's your entire ACO, you can get everybody in a room and actually talk through programs and changes and the like. But if you are a huge organization that's covering 30 hospitals, 3 states, and 2,000 employed physicians, it's really hard to make changes across the organization. And so that was kind of the story that we'd heard in the past. One of the things that might be the case here, particularly looking at the hospital-led ACOs, is that the ones that have the smaller population tended to be more successful. Now, there are very, very few hospitals that only see 10,000 patients in a year. They're seeing many more, particularly those that are joining these ACO programs. And so for these hospital-led organizations, it's usually a subset of their population. And so maybe they're just focusing on a single primary care practice and trying to say, what can we do here? Maybe they're starting to build the ACO around a specific demographic or population. So maybe it's more of their chronically ill patients. But I think it matches what we've seen kind of with past results, where organizations that take a more targeted approach have the ability to see results sooner. Because it's hard to make changes to a very large population, because it's hard to segment and say, should we be focusing on cardiovascular disease? Should we be focusing on diabetes? Should we be focusing on readmission reductions? Whatever it is. But if you have a smaller population that's a little bit more homogeneous, it's easier to make some of those changes. And that's one of the things that we've seen, at least anecdotally, with some of these hospital-led ones, is that they build it around a small portion of their population, and then they have the plans to ultimately expand it more broadly.
Thanks, David.
Hey, thanks, David. Will, before you jump back in, David, we can hear you and it's legible, it's intelligible, but it's still a little rough. And maybe you could try logging out, if you're on a computer, logging out of your audio and coming back in, if that makes a difference. But we don't want you to leave. So don't risk it.
I'll try another approach. Okay.
Sounds good. Will, the next slide.
Sure. So this slide shows some of those numbers by ACO type. Again, similar to prior years, physician group-led ACOs were achieving the highest percentage of shared savings and the best net per beneficiary savings, which this year was about $70 per beneficiary. In previous years, integrated and hospital-led ACOs were both running net losses, but this year both groups improved. Actually, all groups improved, which is something I wanted to note. The ability to achieve shared savings improved across all types of ACOs, and the improvement in integrated ACOs brought them into the positive. But one thing that we're still seeing is that hospital-led ACOs are, as on average, they're losing dollars per beneficiary.
And this goes back to that trend that we've seen for many years, which is where is there money to be taken out of the system? And it's really hard to take money out of the system if you're a hospital and you depend on that fee-for-service kind of revenue. And keep in mind that for many of these ACOs, their ACO population is a small minority of the total patients that they see. It might be less than 10%. And so you can't make substantive changes that will affect the 90% of your fee-for-service system based on 10% of your patient population. On the alternative side, the physicians are in a great position because they're providing more outpatient services, trying to reduce inpatient utilization. And that leads to more fee-for-service revenue in the short term, but then greater payments in the long term, as well as they start to see some of those savings. So just a recognition that this hospital-focused model is always going to be difficult if the primary mechanism to lower costs is by reducing those hospitalizations.
Great, thank you. So on this slide, this is where I can go back to a point earlier where we were sort of putting the asterisk on, net savings being positive for the first time in the program. So they calculate that based off of the benchmark, and there's been a lot of discussion in the literature, the second bullet that I have on the slide here, about whether or not that's an appropriate counterfactual, or at least how it compares to a more true counterfactual. And there was a highly cited piece on the blog by Mark Chernow last year that talked about it underestimating, and just a few days ago, I think it was late last week, J. Michael McWilliams' group out of Harvard published a piece in the New England Journal of Medicine that was able to calculate this for the first 3 years of the program, and they actually found that the benchmarks were underestimating true savings by a factor of 2.8. So I wanted to point that out. Most likely the estimates that we're presenting here are actually an underestimate of the truth, but one trend that we see that's fairly clear, which we saw in previous years, is when ACOs had higher benchmarks, they had a higher likelihood of shared savings. And one of the theories would simply be that they enter the program with more fat to cut, so they're able to do that. And this slide shows that pattern. It's not perfectly linear, but you can see it's a pretty clear pattern by benchmark and percent with shared savings.
One thing to keep in mind with the benchmark is that there are a lot of organizations that are pretty efficient to begin with, but are still figuring out a way to pull out more savings out of the system. And I think those are the ones that we really need to be learning from. And that's what the ACLC is starting to do, is seeing some of these highest performing organizations, and that it's distributing in the case study briefs, and really learning from them and saying, what happens if you take the programs and the approaches that are being used in these low benchmark ACOs that are seeing savings, and then you start to apply them in those that don't have the same history of efficiency. And I think that's the real excitement of this, is seeing, let's learn from the best and really bring everybody up to speed in the same way.
So this slide shows a scatter plot between the actual ACO spending compared to the benchmark, where if they're on the bottom of the line, they had a loss. If they're on the top of the line, they saved money. This is not shared savings, just aggregate savings. And then on the horizontal axis is their aggregate composite quality score. And this scatter plot, as we've seen in previous years, just shows that there's really not a lot of correlation between composite quality score and spending. This has been something that has been discussed in the program a lot, just how strongly is quality tied, is sort of achieving a threshold, is that actually related to the program's success? And here we're not quite sure. But when we did look into variation in composite quality scores by a lot of the traits that we examined, I will note that the opposite pattern based on benchmark, ACOs that had lower benchmarks, who we may on average label as more efficient, had higher quality scores, and physician-led ACOs had very slightly higher quality scores. So this slide on the left, we're looking at the actual savings by state, and you will notice that there are some states in the Pacific Northwest that had more larger losses on average, and then in the New England area, a little bit of an average loss. But when you compare this to the map from last year, one thing that stood out right away was just a significantly less number of red and darker orange states. So what we're taking away from that is the program is improving on average. The ability to achieve shared savings is improving, and it's improving across most states.
One interesting thing about this is that where the most activity in terms of ACOs growing is also in the South. So the South has the highest net savings, but also the most growth. And we looked and tried to adjust for the benchmark, saying maybe it just tended to have higher benchmarks in the South, but that wasn't the case. So we've been adjusting for that. The South, for whatever reason, still seems to have just better net results. Not sure what it is in the water down there, but something hopefully we could learn from.
So I wanted to make sure to dedicate at least a short slide to the new proposed rule regarding the Medicare Shared Savings Program. Hopefully all of you have sat down and enjoyed the several hundred pages of rules. Fortunately, we have some people on our team that have had the ability to do that. I won't go into much detail, but at a high level, there is an increased emphasis on risk in the proposed rule. They did away with the 1 + 2, 3, or they're proposing track system, and proposing replacing it with a basic and an enhanced system. And the key takeaway from that, without going into the details, is it's proposing shifting ACOs, no matter when you enter or what type you are, to downside risk in a faster time frame. If you are already in the program, it basically gives you 1 year to stay in upside only risk. If you're a new program, you have 2 years. And then on the second bullet, they are formally proposing to define ACOs based on high and low revenue. And this, if you look at how that classifies them, it's primarily the hospital-led ACOs are getting classified as higher revenue. And those with higher revenue, they're taking on, or they're putting them on an enhanced track to take risk on more quickly than low revenue ACOs. They are also offering other benchmarking support to smaller ACOs, but it puts essentially putting a little bit more pressure on hospital ACOs. One implication on the bottom side of the slide here that we have investigated in actually a lot more detail in a study that's under review right now is, what causes ACOs to exit. And one thing to watch with this proposed change is preliminary data does show that downside risk ACOs are performing better, but the data is very preliminary. There's not a lot out there. And for a lot of ACOs, though, they've expressed generally that they're not ready to take on risk. NACOS has been pretty clear on numerous occasions that the current rule, which is the 2 agreement periods or 6 years to stay in upside risk, was not enough time. So if you're forcing ACOs into a 2-year window of upside only risk at maximum, and there's a data lag of 1 year to see your data from the program, it really puts younger ACOs in a scary situation. And I will add as a teaser for analysis that, and this is backed up by the shared savings increasing after year 3 in this results, but we would suggest that 3 years is probably a better window of time, but the current proposal is 1 to 2 years.
And this raises the issue of what should really be the goal of the ACO program. Is it just savings? So anything better than the baseline? So if we're able to save, $35 per patient, then we say that's successful, or should we be striving for something more? And this is something that CMS has not yet given clear direction on. There was also a study that was in the Health Affairs blog that came out this week that was looking at the using a counterfactual to alternative organizations as opposed to the benchmark, and the net of their findings was that the first 3 years of the ACO program saved Medicare money, but it was only about 1/3 of 1%. And this was similar to the Michael McWilliams paper that came out. And I think that it's a valid question is it sufficient to save 1/3 of 1%? What are we really trying to drive toward? And what should Medicare kind of look as their gold standard or their expectation. If you look at the next generation ACO program, there's basically a mandated saving that has to happen. So before the ACO can receive any bonus payments or really show that they've seen savings, they have to get above this minimum savings rate in a sense. Basically, Medicare takes their savings outright at the start. Is that the approach that should also happen with the shared savings program? I don't have a good question or good answer to it, but I think it's something that we need to think about, but also that Medicare needs to be grappling with.
And then to wrap things up.
Yeah, we're coming right in our time, so good luck getting through this one.
Well, we already talked about the first bullet, so I can skip that. And simply on the second bullet, I teased that before, we just need better evidence on downside risk. The preliminary evidence suggests that they are saving money and performing better. That could also just be related to a lot of them being more advanced organizations, so we need to figure that out. But then more importantly, how do you become a successful ACO? What specific infrastructure and competencies are most important? And particularly for smaller ACOs, they still need care redesign support. They're very cash constrained, and we've heard from interviews that it can cost $1 million per ACO as a startup cost.
Well, thank you, David, and thank you, Will. This is a lot of information to think through, and we will do more processing about this, and there's more to say, and some of it we'll talk at our member meeting in October. Got a few questions that have come in, and we don't really have a lot of time, but let me hit on a couple of them. One is about, is there any way to determine the use of chronic care management services and fees among ACOs? As Michael Silverman saying, this had significant change for 2017. Any comments on chronic care management services?
Yeah, so this is something that is not available strictly from Medicare. They're not directly evaluating or monitoring this, but it is something that we have started to look at through our survey. So we do an annual survey of ACOs. We partner with NACOs to look at this. And what we found is that, yeah, there is some difference. So organizations that do more around kind of patient management, and it's not just chronic care management, but broader population management, the more activities that they're involved with, the better they tend to do and perform. And so there is some evidence for that. The challenge that you grapple with, though, as a researcher is it's not sufficient to say somebody is doing something. You want to say, how well are they doing it? Every basketball team puts 5 players on the court, but there's a huge difference between a little league team and a professional team, and so it's not enough just to say you put 5 players on the court, but what are you actually doing and how well are you doing it? And that's something that we still need to figure out. Is it's not just enough to do chronic care management, but what does it mean to do it well?
Thank you, David. We're out of time. Had a few more questions come in, but we'll answer those offline after the webinar, and appreciate those who submitted. We appreciate all those who joined us. It was really informative, again, really timely. We'll get back to more information again coming. We'll cover some of the member meeting, and I'll just put a plug for that one more time here. Audio recording will come out in our Tuesday news release that we send weekly, but if you want to reach out, we can get you something earlier along with the slide deck. So Dr. Muhlestein, Dr. Bleser, thank you for joining us.
Thank you.
You're welcome.
All right, thank you all. Take care.